Hello, I'm Alan B. Richards from Shreveport, Louisiana, in the southern part of the United States. I'm going to be speaking on new classifications and insights for retinopathy prematurity. I've worked in Ukraine and had the good fortune of meeting many of you since 2012. I'm sorry I cannot be there in person. I'll be looking off screen toward my English slides, so please excuse me for that during the presentation. I have no financial disclosures or conflicts of interest with the material in this presentation. We're going to briefly review the International Classification of ROP first and second edition first. We're going to outline the third International Classification of ROP, and then we'll outline current indications for treatment and the advantages and drawbacks of intravitreal injection. The first International Classification of Retinopathy Prematurity in 1984 created international standards for exams which were not standardized at all at that time. It created zones 1 through 3, lower the zone, worse the disease, and stages 1 through 5, higher the stage, worse the disease. Created 12 clock hours for identification of location of disease, and defined plus disease. And remember that the standard plus disease slide from 1984 is no longer used. These are the zones. Zone 1, a circle centered on the optic nerve with a radius of twice the distance from the optic nerve to the macula. Zone 2, a circle centered on the optic nerve extending to the nasal oral serrata and the equidistant temporally. And Zone 3, the remainder of the retina. The example of stage 1, ignore these white retinal highlights from the camera. You can see a white ridge without elevation or red tissue attached. Stage 2 is a thicker ridge. The distinction between zone 1 and 2 is not really significant. In stage 2, you can have retinal vessels leaving the plane of the retina, entering the ridge. That's still stage 2. Stage 3, you can see that the ridge is no longer has smooth edges, but what's called a red ragged ridge that can be elevated with neovascular tissue posterior to the ridge, on the ridge, or slightly above the ridge. In 1987, there was a classification of retinal detachment. A 4A detachment was defined as a retinal detachment without the fovea attached. Now you can see temporally the red elevated stage 3 and elevated retina as well. The retina is lifted off, creating a temporal retinal detachment. At this stage, the child urgently needs a lens-sparing vitrectomy to prevent progression. In the middle slide, you can see the detachment has extended to the fovea with loss of central vision. In the third slide, you can see fibrotic tissue extending and dragging the disc. Advanced retinal detachment. This is an example of an open funnel retinal detachment, and on the right is an example of a open anteriorly but closed posteriorly detachment, which would be much more difficult to repair. In 2005, further addendums to the classification were done. AP-ROP was defined as aggressive posterior retinopathy prematurity. In the new classification, we'll see the new name drops the posterior, and the disorder is called aggressive retinopathy of prematurity. The highlights of the third edition International Classification of ROP in 2022: the definition of a posterior zone 2, a new zone, notch extending into zone 1, a new classification of retinal attachments 5A to C. Plus disease is defined as a spectrum. As we mentioned, the replacement of AP-ROP with the new name aggressive ROP or AROP. Descriptions of regression of ROP. The importance of a persistent peripheral avascular zone. Types of reactivation of ROP. And different findings of reactivation of ROP after intravitreal anti-VEGF agents. Posterior zone 2 is defined as an area just outside zone 1 extending 2 disc diameters. We've known for some time that disease in this area is more ominous than more peripheral zone 2 disease, and disease in posterior zone 2 can act much more like zone 1 disease and should be followed closely. Previously, there's been discussion, as it has been observed, that often patients have largely zone 2 disease, but may have a notch, usually temporally, extending into zone 1. Didn't know how to classify this, and there was argument among experts. Now, it's recommended that this picture with zone 2 with a notch extending into zone 1 be noted as zone 1 secondary to notch. There are new stages of stage 5 total retinal detachment. In 5A, the optic disc is visible. It's typically an open funnel. Stage 5B, the optic disc is not visible. The disc is obscured by fibroelastic tissue, and it's typically a fairly closed funnel. 5C is more advanced. There is anterior displacement of the iris lens complex, shallow anterior chamber, and central corneal opacity, typically a closed funnel. This classification should be helpful in identifying which surgical procedures are most effective for each type. Plus disease is now recognized as a spectrum. Instead of a standard slide, these are 6 slides the committee gave from normal to plus. You can still use the terms plus and pre-plus indicating a milder form of venous dilatation, arterial tortuosity, not severe enough to be called plus disease, but not normal. Another expert has 9 slides showing the spectrum from normal to plus. I carry these on my iPhone as my colleague and I see ROP on different weeks, and when we see a patient, we can classify the plus or pre-plus from 1 through 9. So there's a vascular spectrum, as you can see from these slides. So we're going to diagnose plus or pre-plus by the appearance of the vessels only in zone 1, not only within a narrow angle field, not by the number of quadrants, not by the type of vessels. It's also important to realize that the venous dilatation and tortuosity usually begins peripherally. So if one sees these vascular changes peripherally, the patient should be watched carefully, as plus disease may develop within a week or 2. Future implications are that perhaps artificial intelligence may be used with retinal photography to help identify plus disease. These are 6 slides showing the spectrum of pre-plus to plus. Slide A is mild pre-plus disease. Slide B is more severe pre-plus. Slide C is pre-plus with moderate arterial tortuosity, venous dilatation. Slide D, this would be called plus disease, milder but definite plus disease. And slides E and F are more severe plus disease. We'd like to treat the patient when they first develop something like slide D, although sometimes plus disease comes on quite rapidly. So the term aggressive ROP, AROP, now replaces the term aggressive posterior ROP, as aggressive ROP may occur in zone 2, particularly 2A, or zone 1. Key diagnostic features of this type of ROP: The disease often progresses rapidly within days. It may be not sufficient to see the patient in 1 week. You may have to see the patient in a few days. Severe plus disease can develop with shunts and hemorrhages. The neovascularization, as seen here, is often flat, difficult to see, but present on fluorescein angiogram. But the disease does not have to be extremely posterior to still be aggressive, hence the drop of the term posterior. The neovascularization mentioned is deceptively featureless, particularly in a premature child during a live exam, with often some obscuration of the ocular media. The neovascularization can be very difficult to see, but on fluorescein angiogram, marked neovascularization is present. Same with this slide. These are further examples of aggressive ROP with hemorrhages, additional hemorrhages. Here's a ridge, which is difficult to see, but present with plus disease. It's much easier to see the plus disease than the neovascularization. So we actually treat with anti-VEGF agents this posterior disease with any significant dilatation. We don't really wait for typical classic plus disease in these. And here again is a picture of the ridge. You can see the ridge is faint, perhaps seen here, and the ridge doesn't extend past the macula. This is an ideal case for the use of intravitreal anti-VEGF agent rather than laser, which one would have to laser the macula itself to eliminate the disease. Now, let's talk about ROP regression. After laser, we know that the vessel width first decreases, sometimes in the first few days. The tortuosity of the arterioles then decreases, sometimes into the first week and the second week. After intravitreal anti-VEGF agents, the regression is more rapid, as the anti-VEGF agent binds VEGF in the vitreous immediately, unlike a laser, but there's higher risk of regression as the ischemic retina and activity in the retina may persist and produce additional VEGF and additional disease. There's discussion of a persistent avascular zone, PAZ, which can occur with ROP regression without treatment, or particularly after intravitreal anti-VEGF agents, and may lead to later peripheral changes, lattice, retinal hose, tears, or retinal attachment. Can be in the first year of life, first 2 or 3 years of life, or even much later in life. So ROP regression is increasingly important after anti-VEGF agents. Some patients after anti-VEGF agents, the entire retina vascularizes, but many they do not. First signs of regression are vascular, decreased plus disease, as I said, is more rapid after anti-VEGF agents than laser, and thinning and whitening to the neovascular tissue. We mentioned the peripheral avascular retina, persistent avascular retina is prone to retinal changes and further complications. How do we manage a persistent avascular area? Does it require laser treatment? We don't have answers for all those questions, but many are increasingly applying laser if the retina does not vascularize fully. Reactivation of ROP may occur weeks, months, or even years after intravitreal anti-VEGF agents. The incidence of this reactivation is not known, likely 30 to 50%. Most commonly occurs age 37 to 60 weeks, but can occur much later. The signs of reactivation: a new demarcation line, new stage 3 or new plus disease. The reactivation can be at the old demarcation line or a new, more peripheral demarcation line. The vessels are often very difficult to visualize. As you can see here, not seen easily here, seen well on fluorescein angiogram. ROP reactivation may occur after regressed ROP, as we mentioned. This is an article that was quite disturbing on the right. late onset retinal findings and complications after untreated regressed ROP. None of these infants fit the criteria for treatment with laser or anti-VEGF agents, but they did not regress completely. This article included 203 patients, average age 34 years, ranging from age 7 to 76. 30% had retinal attachments, 54% had lattice, 34% atrophic holes, 30% retinal tears, and 12% retinoschisis. And this is an example of persistent peripheral changes, lattice, pigmentary changes, holes that can occur. Now, the persistent avascular zones we mentioned can occur with ROP regression without treatment after intravitreal or anti-VEGF agents. With adequate laser, this is not a problem. As we mentioned, can lead to later peripheral changes. ROP reactivation is particularly important after anti-VEGF. These patients need close follow-up if one does not perform laser. And the reactivation may not progress through the normal sequence of stages of acute disease, and you may have recurrent vascular dilatation, tortuosity, and you use, again, plus or pre-plus for the reactivation. The extraretinal vessels may be very delicate compared to acute ROP, so you're going to use the modifier reactivated for the most anterior ridge. Laser versus anti-VEGF agents, still a discussion worldwide. Laser is still very effective for most ROP. Eliminates a source of excess VEGF production by obliterating the avascular retina. This was a presentation we gave to the National Pediatric Ophthalmology Meeting in the United States. Treatment of ROP in infants weighing less than 500 grams at birth. We presented in 2017, 16 infants. Average gestational age 24.2 weeks, average birth weight 446 grams. Every laser was successful. However, since that time, we've seen aggressive posterior ROP that does not respond to laser and is treated best by anti-VEGF agents. And Ukraine will increasingly see, once recovery begins, more and more smaller babies with more aggressive disease. What are the indications for anti-VEGF agents? Well, I would suggest very posterior aggressive disease. Anti-VEGF agents have become the treatment of choice for this type of disease in ROP in the United States. As we mentioned, anti-VEGF works more quickly, 24 to 48 hours rather than days. Increasingly, most centers now treat with delayed laser 3 to 10 weeks later. We treat these before they leave the NICU because we live in a very rural state and transportation is often difficult for many of our patients. Advantages: more rapid treatment, less induced myopia because less laser is ultimately applied. Disadvantages: most anti-VEGF agents suppress systemic vascular endothelial growth factor for up to 12 weeks. During this time, the brain, the lungs, the kidneys, and other organs are developing, and impairment of vascularization can impair these organs, particularly the brain. Most likely, there's increased disability, cerebral palsy. This slide shows a graph of systemic suppression of VEGF from bevacizumab or Avastin. The serum levels in the IV Avastin group were about 50% of those in the laser-treated group. These are the two different doses of Avastin with suppressed systemic VEGF levels, and these are the laser. Aflibercept or Eylea is a new agent, but still suppresses systemic VEGF. In this article, Eylea, aflibercept, suppressed VEGF even more than Avastin, and as you can see, ranibizumab or Lucentis had only brief suppression of systemic VEGF. So what would we consider the ideal treatment of aggressive RLP? Inject intravitreal Lucentis, ranibizumab, 0.25 milligrams into each eye. If the disease reactivates and is posterior, you can safely re-inject without fear of additional suppression of systemic VEGF. Once the vessels grow into zone 2, laser can be applied. So Lucentis is definitely much safer than Avastin or Eylea. I know there's concern about cost, as there is in the United States. There are some biosimilars available. We don't, at this time, have enough data to use those, but we should be following those developments. Recent editorial by one of the U.S. experts on RLP comparing low doses of Avastin intravitreal versus normal doses showed there was twice as much severe disability with normal dose Avastin than very low dose Avastin, showing that the usual doses injected intravitreally probably do cause cerebral palsy. This is a recent article from California Outstanding Medical Center in which they treated 34 neonates, 68 eyes, mean gestational age 24 weeks, mean birth weight 657 grams. None of these patients progressed to stage 4 or 5. Refractive results were impressive. High myopia, only 7%. Emmetropia, no glasses, 39%. Low hyperopia, myopia, 22%. Some patients did need treatment after intravitreal Lucentis before they had the laser. Sometimes the first injection was done at age 34 weeks. In 18%, there was a second injection at 42 weeks. 82% had a laser, average 43 weeks. 10% additional laser, age 46 weeks. Summary. I reviewed the standard disease classification essential for advancing clinical care and research, and we need to all try to adhere to this classification for communication to one another and better treatment. The key changes: posterior zone 2, the notch extending into zone 1, classification of retinal attachments A through C, plus disease seen as a spectrum, the new term aggressive RLP replacing APRLP, the forms of RLP regression and reactivation after either anti-VEGF agents or regressed RLP. And the goal, of course, is to improve our quality and standardization of RLP care worldwide and provide the foundation for improving clinical care and research in the future. And I want to acknowledge Michael Chang, who was on the committee, who shared some of his slides and helped me with this lecture. Thank you very much.